This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Welcome to the next episode of the One Thing Podcast. In this episode, I welcome on Dr. Dawn Ipsen. Dr. Ipsen is a pharmacist that is out of the Seattle area. She is a professor at the University of Washington and at Bastyr University, also is the owner of two very successful compound pharmacies, Kussler's Pharmacy in Snohomish, Washington, and Clark's Pharmacy in Bellevue, Washington. She was a previous guest on our podcast and speaking to us about Low Dose Naltrexone. Today, she's coming back to help us connect some dots and find out some solutions for long COVID. We had a previous episode with Dr. Amy Prohl, who helped really piece together what is the underlying process that is going on with long COVID patients and people who are dealing with sequelae from having a COVID infection. And this episode, we went into some solutions that can help people stabilize and perhaps get back to their life and start to repair from the process of dealing with long COVID. And Dr. Ipsen really feels that neuroinflammation is the underlying process that we need to address with long COVID patients. That's inflammation of the central nervous system primarily. And she has, through her experience working in compounding pharmacy, really wrapped her head around what are some good solutions for these conditions. So in this episode, we'll talk about therapies that are available and how they work and what they might do to help alleviate some of the symptoms of long COVID. So I hope this is helpful for many people who are clinicians and people who are dealing with long COVID, and that you get some ideas to help get restored and back to your life as was previously before dealing with the COVID-19 infection. So without further ado, I welcome you to the next episode of the One Thing Podcast. Dr. Ipsen, welcome back to the One Thing Podcast. It's great to reconnect with you again.
It is so great to be here. I'm always honored, and I know this is going to be a lot of fun today. So thank you for having me.
You're welcome. I'd like to jump right in and talk a little bit about COVID and your experience. You were looking back at March, April of 2020. You were one of the leaders in our community of really figuring out how we're going to respond to this. I'd just love to hear your reflection back on that time. And what was the impetus in your sort of call to action?
Yeah, for sure. I'm blessed that one of my staff made me a memory book of that time, because I knew that as we were going through it, it was so fast, furious, ever changing, moment by moment sometimes, that I knew as we were doing it that I would want to remember these things, but there was no time for journaling, no time for keeping notes or tracking what we're doing. But I do distinctly remember March 23rd of 2020. That was the day. It was a Saturday, I believe, if my numbers are right. And I staffed that day at Kussler's compounding pharmacy up in Snohomish, the one that's open on the weekend. And I went home that day and I looked at my husband, who's also our business manager, and I said, we have to close the doors. We have to go closed door, because everybody was trying to understand, what is it? We didn't have any clear guidelines yet as to how do we think, respond, act. And there were great concerns. There were patient safety concerns of multiple patients in the pharmacy at the same time, many of them at that point not masked. There was great safety concerns around. I felt a call to keep my staff healthy so that we could continue to be there every single day to help the patients that were going to need us. So that was like day one for me, was that March 23rd. So we made some big changes for a while, and we're really trying to follow the science as best we could, trying to see what science was out there. And as we were doing that, the whole thing was always of, how do I, as the leader of my pharmacies, of both Kussler's and Clark's, keep patients safe, keep staff safe, and then what does the community need? And as we were driving through that, of course, we were the first pharmacy in Snohomish County to offer COVID vaccinations. Very first.
Mm-hmm.
And it's partly because we had relationships with our health department for a decade plus at that point. So we knew who to get a hold of and how to respond. And we had done things like this before with like H1N1. So they saw us already as being able to react quickly and adapt. And that was really cool. I'll never forget also New Year's Eve. So December 31st of 2020, the vaccine had literally been approved maybe 7 days before that. The vaccine was set to show up at our pharmacy on New Year's Eve. And my entire pharmacy team stayed that night after we closed. We actually toasted with sparkling apple cider for a pharmacy.
Yes.
And we did our COVID vaccine training and got ready to roll for the following week on taking care of people where the vaccine was appropriate, where they had decided they wanted it, where it all fit. And what was super cool there is our first people we were helping were private practice doctors who were getting turned away by bigger facilities that, we were having healthcare clinics to take care of healthcare providers for vaccines, but because they weren't tied to bigger groups like Providence, Virginia, Mason, and all that, they were being told, no, you don't qualify.
Yeah.
So that we took care of them first. Then the second group that we were taking care of was when senior citizens became called to, hey, it's your turn. And partly because the areas in Snohomish specifically, or Snohomish County, would be long lines, hours of waiting, lots of standing. And so we were helping the seniors who were wheelchair bound, who couldn't stand in a line and doing that. And then third of that was school professionals, of helping them get the vaccine so that we could get our kids back in schools and get them back into some sort of normalcy. So that was the COVID vaccine portion. And then we were also, along with that, one of the very first pharmacies in our state to be compounding, custom making hand sanitizer from ethyl alcohol and donating it by the gallons to all of that. So that was kind of my oh my gosh, look what we did. It was incredible.
Yeah, I really thank you for your efforts, because it was, I think at that time, people were very lost and scared. And I think, it's easy to look backwards and make this kind of new reality of what we've all just experienced. But the reality of that time was, it was quite scary, and there was so much uncertainty, and to see someone take action and, basically jump into the trenches it was really, it provided a lot of comfort and safety, I think, for all of us. So thank you.
Oh, happy to do it. And one thing that's really important to note, it wasn't alone. I quickly figured out my role was coordinating volunteers. And I had over 50 healthcare providers volunteering time to do this, along with my staff. So it was a huge effort, and happy to do it. Yeah.
So we're still in this in a kind of different way. What, compared to 2020, how is COVID impacting your pharmacy these days? What do you hear from people?
Yeah, you're right. We still have COVID, and it's in our communities. It's still at, fairly large numbers, especially if we look back to what we used to think was large. And one thing that seems to be a little bit of a trend is a bit less severity of outcomes for most patients, not all, of course. We have a new normal. Like now I still have this huge sense of protecting of patients and staff. So any little sniffle, tickle, illness of any kind is looked at so differently than pre-COVID, so differently. I think this is true of many healthcare providers. Before COVID, we just worked. We worked every day. Yeah. Didn't matter if we didn't feel great. That's what we did. And so we had this culture of like, you show up no matter what. And now we've had to put the brakes on a little bit of, yes, but how do we do that and maintain preventing spread of really any kind of illness, whether it's a cold or COVID directly? So we still see patients that are actively sick with COVID. And I think we probably maybe always will. I'll sort of be surprised if that totally disappears in my career time frame. But we also now see a lot more patients who just didn't recover like we expected or thought they should. And then trying to walk with them and navigate what is this, have understanding to it, and try to provide therapy and treatment and relief of symptoms and improvement of quality of life. So,
yeah. And I'm curious if that scenario is new to your patient or client population. I mean, it seems like you've been serving sort of people who have chronic patterns and chronic illness for a long time. Does this have a different feel to it?
Yeah, it definitely has a different feel to it. Their symptoms sometimes have similarities. And I think that that's really what we're leaning on right now is because, you're right. I have been in the practice of helping chronically ill patients pretty much my whole career. So MCAS, POTS, and all of those, Alzheimer's, Parkinson's, on and on. And so now what we're trying to do is, well, your diagnosis is not those things, but your disease pattern or your symptom pattern is reflective of things that are within those other, maybe slightly more known disease pathways. And so then with that, we're leaning really heavy on an area of lack of research, and it's of nobody's fault. It's just this is new. We haven't had time to simmer and sit with it and really learn enough about it to know. So we are needing to go with our knowledge base of these have similarities. Therefore, maybe these types of thoughts and pathways of treatment could prove beneficial to that similar yet different, unique patient. And the other thing that's unique too is we call it long COVID or post-COVID syndrome, but the patients don't all look the same. There's so much diversity within that group.
Yeah. I mean, the symptom list of, kind of the bucket of symptoms, I think is like 200 or so of different ways the long COVID or post-acute sequelae of COVID-19 is being referred to. So I can see that. And it's interesting. Do you find that one of those disease conditions is a better model or lens to look through than others? Like I know some people have really focused on that this looks a lot like chronic fatigue syndrome and fibromyalgia that we've seen, sort of a post-viral syndrome. Do you find that just when you're reading the research or wrapping your head around about therapies that seem to be appropriate for people with long COVID, do you find a condition is like your go-to model to look at?
Not necessarily, but what I take from that and what we know at this point is this appears to be highly inflammatory. And so if we look at it from this appears to be overall an immune dysregulation and probably very inflammatory based, which you're right, that does hit fibro and it does hit, these other conditions as well. But we do know, okay, well, how do you turn down the burn? So how do you turn down that inflammation? There's lots and lots of things that play into it. I really like the bucket or the pot method of thinking about that. Like everybody has a think of a black kettle pot.
Mm-hmm.
And there's so many things that dip into that pot, COVID virus being one of those things, that then it starts to at some point overfill and flow over. So if you start picking away even at small portions of reducing the boil of that pot, you can have a really great positive impact on that patient. It could be things as simple as what inflammatory exposures are they getting at in their environment? What dietary exposures, and I think as we all really know quite well, sugar and dairy tend to be really top inflammatory producers in most people. So a simple, I know it's not simple, but a change in the diet could have a huge impact. Are there supplements that could be used that we know are anti-inflammatory in some patients? So even correct vitamin D levels can be very beneficial. But then if we get beyond that, we start looking at, other treatments in that sense. Low dose naltrexone comes to mind for me really quickly, just because we do have decades of experience of that drug being really impactful at 3 or 4 different pathways. The two probably one most important is its effect on microglial cells in helping the immune system to function correctly, which then reduces inflammatory response. So that's a really big one. And sort of another one too that sort of comes to mind is methylene blue is being looked at quite heavily as well at its effect as a nootropic and reducing brain inflammation because it's so antioxidant. So there's lots of little nuggets of things that we know from other conditions that are symptomatically quite similar to what we're seeing now.
Mm-hmm. Mm-hmm. So neuroinflammation, just from a 20,000 foot view, what does that mean to you?
Yeah. So neuroinflammation is when you have inflammation that's primarily located in the brain or spinal cord. And it's usually due to cytokine release, histamines that are there, nerve cells that are not functioning correctly. But from a patient perspective, what does that mean? Well, that means that you have patients who are exhausted, who are mentally not firing correctly. So it can be everything from, I used to be able to multitask. Now I cannot. I used to be able to just keep that short list in my brain. I used to be able to recall their name right like that, where now they cannot do those things. And it even goes further, and it really affects their wakefulness and also their sleep as well. So maybe they used to have all that under control, and now we have really abnormal sleep patterns, which then that becomes a vicious cycle of now we're more inflamed and we're less have less synaptic connections and less output available in the brain.
Yeah. Yeah. So I think there's been a lot of thought about like what's causing this, what's driving up this inflammation in long COVID. And, I've seen theories based on, residual viruses or activation of previous infections, gut problems, circulation problems, or it could be just all of the above. And I think it's really interesting for us doctors and researchers and clinicians and providers to talk about this and say, what's the root cause? But the same token, as you and I were talking about, like people aren't feeling well. So one, they want to start feeling better. And two, is like, they might not want to spend 3 to 6 months, investing in lab work and these other tests and things that, just to kind of, they want to get on their feet. And I think that's kind of one of the interesting things about where you really slot in is like, not only do you have a unique position because you're actually offering solutions, but you also see like what people come back for and say, hey, this is helping. This is actually making me feel better, which is really interesting that we don't talk about that. Like that would be the most valuable metric if we knew the refill rate of
Yes.
a therapy.
Yeah. For sure. And you're right. I see it. And what's cool about the compounding pharmacist perspective is I get to work with hundreds of doctors like you doing really great work out there and with little bit different tweaks to approach at times. And then I work with their patients, and my job as the pharmacist is, yes, to customize, make their medicine, but also to try to carry through the messaging that you're giving the patient to try to help them with their best therapy. So counseling, expectations, side effect management, all of those things. But you're right. The number one thing that I get that maybe you don't have as direct feedback on is, are they refilling it? And at our pharmacies, some of the things we do is we actually reach out to patients when they're past due on refills and do a check-in. How's things going with that medication?
Yeah.
And we learn a lot sometimes. We learn about things of, well, I had this question and I just didn't get around to reaching out to you or my doctor, and so I quit taking it. Okay, well, then I get to talk about that and figure out why, and is it appropriate for them to restart? Do I need to help communicate back to the doctor what's going on? But yeah, I get this inside view of, we start this maybe more novel approach to try to treat or, improve quality of life, and did it work? And, oh, cool, it did. So now I can help spread that word back out to, this is some other things that you might want to think about. Yeah.
And it's, and there's also, so many layers to whether a therapy worked or didn't work, to think about, like the right dosage, the right form, what other health conditions are they dealing with? But it's just such a great position, for you to kind of really see and observe and gather data. So a lot of patients who are dealing with long COVID, their life has turned upside down. People who never have had a chronic illness, and all of a sudden, within a matter of a year, all of a sudden they're dealing with this thing where they can't get to work, or they've had to leave their job. And I've had people get fired from their jobs because their performance, or they weren't able to attend work on a regular basis. It's a problem that I think would be best served if clinicians knew some early wins that they could help people with, like early, just stabilizing treatments. So in your formulary of things that you work on, can you kind of give us like a sense of what some of those might be?
Yeah, I'm happy to. And, as I was thinking through this, prepping for today, I really I always like a short list, because I think too much becomes too much.
Yeah.
And these are already patients that are extremely overwhelmed, right? Extremely overwhelmed. Low dose naltrexone. Honestly, I just did a testimonial recording with a patient who's in my community. I ran into her at a holiday thing. We were just casually chatting, and she shared with me, "You changed my life." I'm like, "Well, what do you mean by that?" She goes, "Well, I had COVID and I had all these other things going on. It affected my liver, my gallbladder. I had no energy. I couldn't take care of my kids, let alone run my business. And luckily I had a great doctor who suggested I try low dose naltrexone." And I said, "Tell me more about that." And it was for her particular situation, within days that she started to respond. And I'm like, oh my gosh, people need to know this information, and they're not talking about it, because there is having suddenly a chronic disease when you were a healthy person before is very hard. You do have to go through like a grieving point, and there's some self-consciousness to it. There's denial. There's all these other levels. And it's not until I think people finally go, okay, fine, I've got this thing. I'm not going to let it identify me. I'm going to work to figure out how to fix it, that we can suddenly start getting to that next state of, okay, let's start doing some things about this. And so for me, I have to say, I feel like I beat low dose naltrexone, up and down the block, and I've talked about it for years and years and years. But this is a different use and purpose for it. And it makes sense because this is a condition of inflammation. It's a condition of immune dysregulation. And yes, you're right. A lot of times these patients now, they had COVID and all of a sudden, guess what? Epstein-Barr's back, or these other really chronic underlying things that were stable or kind of laid latent within the body that weren't really affecting them that are now the big deal. And so my thing with low dose naltrexone is I've never, ever in my 20-year career seen it ever hurt anybody when taken appropriately. Never, never, ever. The only 2 patients I've ever seen have significant medical problem with it were actually patients where I talked to the doctor and said, I think this is not a good idea because the patients were on chronic opiate therapies.
Right.
They ended up withdrawing and they had to go to the emergency room, you know, that sort of thing. But other than that, other than those literally 2 patients, it's always just a matter of, did it work? Yes or no? And how helpful was it? Okay. So to me, if you can have a drug where you know you won't hurt somebody and it just might change their life, that's a great combination. And the other thing that goes with that is, unlike a lot of like the immune modulator drugs and the prescription things like that, this one is so much less cost burden to patients than any of those more typical pharmaceutical type drugs. So I like that combo. I love in pharmacy, I love low risk, I love affordability, I love patient access. I think dosing, we're still trying to get our head wrapped around. So we're going with the really traditional normal dosing patterns of start low, increase slow over time. And then with that, you just sort of go by how they tolerate it. I have talked to some patients in my follow-up calls where it's like, I think we went too high too fast for you. And then I really like getting a hold of the doctor, bringing the conversation together and say, hey, you know what? Let's restart. Let's go slower. Because I do feel like sometimes these patients, even though before we would say, oh, they're not sensitive, they are now very sensitive. And less sometimes is more in that group because we don't want to overfire the immune system. We don't want to overstimulate it. And we want to make sure we're really being cognizant of inflammation. So I love that one. That LDN, I think to me, if I had a person who says, I've got a condition of some sort of high level of inflammation, that's my first, have you tried LDN? And if they have and they didn't get the outcome they wanted, okay, let's go back to the drawing board. Probably my number 2 right now, and it's a little bit newer in therapy, so would be Methylene Blue. It's not a new drug. That drug has been around decades for sure. And I would say probably 15 years ago when I used to work with it a lot, it was primarily for the use of bladder situations. So interstitial cystitis, which is an inflammation condition of the bladder. I have a couple of patients, one of which is still a dear friend and patient to me, where Methylene Blue was literally the one therapy that would calm her bladder down. And so I'd worked with it before, but for other reasons, and then started to do more research on this is being looked at differently. The dosing is different, but how it can be brain protective. And there's some beginning stage research occurring currently looking at Methylene Blue for prevention and treatment of Alzheimer's. And if you think about, well, what is Alzheimer's? It happens to also have this huge inflammatory component of the brain. And so that's another one. Now, Methylene Blue, it is a drug that we do have to have a little bit of caution on, I think, from a pharmacy standpoint of it's dosed by weight. So it's not a one size taper go like we're used to with LDN. And it also is an MAOI inhibitor, which means it does have drug interaction potential with medications that, are commonly used in the United States, such as SSRIs and antidepressants. So there's a little string of caution there. But on patients, when I've seen this be helpful, it's typically something that within weeks, the brain clarity, the fog starts to lift, likely due to the anti-inflammatory proportion and brain protective proportion of it that we can get some good clarity outcomes from brain function.
Yeah. So I remember hearing about methylene blue just from various circles within the long COVID world. And I don't know why, but why is there such a resistance to it? Like it seems to have like a pause. And is it just the MAO inhibiting effects, or is it some other aspects? Is it the way it was first used? I'd love to kind of like get some of that out in the open, because I'm hearing some great results from it, but I think there's just kind of just a adoption resistance of that therapy.
Here's my thought on it. One is, yes, we got to watch out for drug interactions, but we do that on drugs all the time.
Yeah.
I feel like methylene blue became sensationalized really quickly. And like if you go on Instagram, you type in methylene blue, you get all these reels of these really, cute beach body people with blue tongues because they're doing drops of methylene blue, and kind of making it a rage, so to speak, where the people you see doing this are clearly people who therapeutically probably don't need it. Yeah. And the reason they're doing that is you can technically go on the internet and just buy this stuff. Now, being a pharmacist and really scientific minded, I definitely do not agree with that. And here's why. It took the FDA back in the day when I was helping bladder patients, it suddenly became unavailable. The FDA was not allowing clean pharmaceutical grade methylene blue into the country of the United States. So it became unavailable, flat. It took me over a year of working with all of my really good FDA licensed and inspected suppliers to be able to get a good, clean version of methylene blue into my pharmacy. So all this really cheap, easy access stuff is two things. It's dye grade, which is supposed to be used in treating fish tanks, and often is laced with lots of impurities, heavy metal impurities, which you and I know, we don't like heavy metals.
Right.
Highly inflammatory.
Yeah.
And so, but it's because you could just Google it and it'd show up at your door, and everybody in the world was playing around with it, which then led to people having problems and side effects and not getting good therapy out of it. And I really think it's because the dosing is wrong, the purity is not right, it's laced with stuff, it's not pharmaceutical grade, and therefore our outcomes and always call them case studies, N's of one, our individual patient responses have not been 100% positive, because you start talking to people, I already did methylene blue and it caused these problems. Well, here's probably why.
Okay. And it seems to obviously work on neuroinflammation, oxidative stress in the brain. Do we know how it works? Do we know more mechanisms than just sort of the effect?
Yeah, a little bit. It gets down to the energy producing cells of the body, and specifically of the brain. They're called mitochondria. And when mitochondria are not working well, honestly, it could cause end of life in some people. And I remember when I was a young pharmacist back in the day, we would actually work with brand new babies and children who were diagnosed with mitochondrial defect. And we would do all sorts of things like compound coenzyme Q10 and all these really great antioxidant preparations to try to feed and help support the mitochondria. Well, methylene blue is kind of doing that too. It helps support the energy production, helps support mitochondrial, and to increase NAD production. And NAD is the substance of life, so to speak. And so that's the pathway primarily. And it does this through a complicated mechanism of inhibiting, this one specific enzyme producing system within the body. But it's working on mitochondria to increase energy.
Okay. And do people generally take it for a short period of time, or is it kind of a ongoing therapy?
Yeah, we're really learning that still. All of the research and studies that I have read myself so far are pretty limited in length of time, 3 to 6 months. I think 6 months might be the longest one I was able to uncover and look at. So unlike LDN, where patients would take that chronically, and we know that that is good and safe, I think we're still learning on methylene blue. And I think always the goal with any therapy is take it, rebuild the system, recover, and try, we don't want people on medicine for life. So I would say I would recommend using caution for super long term at this point until we know more. And really with that too, probably monitoring effects of the drug therapy to learn as much as we can too. It is renally eliminated, hence why when you take methylene blue, your urine is blue to green during that time period. But I do kind of wonder, do we need to have caution with long-term use and renal effects and long-term use and effects on serotonin levels within the body? And is there any buildup? My sense is we probably are in a good, safe dose range based on the dosing that's being talked about. Because like the Alzheimer's studies, they're looking at 300 milligram, which is, in my mind, that's a really big dose. And most of the time with methylene blue for nootropic effects, we're looking at things between 10 to 30 or maybe up to, I think I've seen as high as 90 milligrams in a day. So quite a bit lower. But we have a lot of learning to do yet. And I think because of that, patients should not self-medicate, self-treat. They need to be followed and monitored for that.
Yeah, it reminds me of situations like this where we use nootropics or we're really kind of getting into altering brain inflammation. And do you see sometimes that people get manic or get like a little bit of almost too much stimulation, where they might feel mania or have sleep problems once these therapies are on board? Is that reasonable?
I mean, I think theoretically it's something we watch for, but I can honestly say with methylene blue, with the dosing that I'm currently seeing, we are not getting that feedback from patients of any concern. And that even includes our patients that are being prescribed to take it twice a day, that they seem to still maintain good, reasonable sleep patterns. I've not seen or had any underlying psychosis issues arise from like underlying bipolar, underlying schizophrenia. My own personal experience in taking this medication, I do benefit from the clarity it provides, but I don't go to the sense of like feeling wired. Like, sometimes you take a stimulant like caffeine. If you get too much caffeine, you just feel really buzzy and wired and then can't sleep. That's definitely different. It's not a stimulant in that effect. So even though we may be getting more serotonin levels, I think at the dosing we're using, we're just not bumping it high enough to probably clinically have an impact.
Yeah. It's exciting to learn about these therapies because, I'd say in the last 4 years, we've learned that there's this whole detoxification system in the brain, the glymphatic system. We didn't really know about that up until 4 years ago, that there's like this waste, that accumulation in the brain that needs to be drained and emptied, just like our liver and, the gut. And so it's really, it makes a lot of sense that if inflammation is kind of stuck and there's accumulation of waste products, that if you're able to provide some reduction in that and help the brain clear out, some of this inflammation, it makes a lot of sense. I just think we can no longer think of the brain like we used to, right? It's so much more understanding since we learned about the glymphatic. Do you think about the glymphatic system? Like, is that something that was new to you, or were you just did you just figure that was like, of course this is there. It's just wasn't discovered yet.
No, I think you're right. But it's that hindsight 2020, right? Of looking back and going, oh, that makes so much sense now. Like, think about, this is a good example. When people decide, I'm going to go gluten-free. Like, I feel like this is not healthy for me. I'm feeling like I'm getting effects from that. and then all of a sudden they, cheat or dip into gluten or whatever it might be, one of the first symptoms they get is headache and brain fog. And it lasts for weeks. And so that there says so much about detox pathways. And, and I deal with that too within the hormone replacement world of things. You can get patients, doing hormone replacement therapy with really good, right products, right doses. But if they're not processing and if they're not having, fecal movements every single day and getting these things cleared out of their bodies, of course they're more inflamed. Of course they feel terrible. And sugar's another one that easily does that, where you can have a patient who's maybe not believing you, and you get them to try this little experiment short term. They feel it right away, right? All of a sudden it's oh yeah, I get it. I get how inflamed I am and what that means. So
yeah. And I think the brain is so sensitive to all of this. It's probably, the most sensitive organ if you think about it.
And sometimes I think because we need our brain so much, we really notice those impacts more directly than, say, if it was liver or, another organ where just kind of is in the underlying clearing mode. Brain, you feel it. Brain, if something's wrong with your brain, you're tired, you're not functioning correctly, you're having headaches, you're having visual disturbances. And so when you talk about quality of life, that's a really important organ to try to mitigate problem and help with, so that we can get people back in jobs and back taking care of their kids and doing their normal things. So, yeah.
So with LDN, we see, sort of a shift in the immune system, kind of a dampening of some pro-inflammatory cytokines. And with the Methylene Blue, we see more of help with mitochondria, and which helps with reduction of oxidative stress and other components. So those are two nice layers, I guess, to kind of start off with the long COVID brain, I guess, as far as what people are dealing with in the central nervous system. I know you use a few other therapies, kind of on your short list. What other things would you say are good angles or good additions to take?
Yeah, so another one that really comes to mind, it's a compounded nasal spray with a proprietary base called Synapsin in it, and typically paired with methylcobalamin. So Synapsin is a blend of the ginsenoside RG3 and nicotinamide riboside, and it has to be the riboside because it has to do with bioavailability. Those are also... That combination it's kind of like LDN and methylene blue combined, in the sense of helps with the immune process of the brain, but also helps with the NAD production or energy production of the mitochondria.
Yeah.
And then the reason we typically will put methylcobalamin or vitamin B12 in the methylated form in with it is that specific nutrient has been highly linked to with deficiency, higher ranks of Alzheimer's and dementia. So you're supporting another pathway of NAD production by adding that into it. Of course, in my mind, if you look at from a patient compliance standpoint, especially within the U.S. culture, we love pills, right? So anytime it can be like an LDN or a methylene blue in a capsule form, that's really easy for us to accommodate. This is a nasal spray, which the benefit of the nasal spray is you are getting more direct delivery of medication up closest to the brain as possible, and have that mucosal absorption available to make that bioavailable. There's anything we take by stomach, it goes through what's called a first pass effect, which then it's metabolized, then it goes into your bloodstream, then it goes up to your brain, and you finally get the benefit or the effect. So I like those a lot. From a clinical standpoint, I am still seeing ivermectin being used. And to me, I think it's just a lot of unknown, and we don't know for sure. But when I think about a drug from a safety profile, I did a deep dive into ivermectin several months to a year ago, probably even more than that now, time flies, and was like, okay, we are seeing this being done. Is it safe? And so what I was able to show is that with the dosing range being appropriate by patient, that ivermectin for most patients should be very safe and well tolerated. And I honestly counsel my patients that it's experimental and we just don't know. I know that the last study that came out with ivermectin in acute disease of COVID showed no benefit. And I don't disagree with what that data said, but I also wonder if we just haven't hit the metrics of study design appropriately yet.
Yeah.
And that's the part where I think most of the studies that have been produced have been done through big hospital organizations. Therefore, these are probably mostly patients who have had disease for a while and then finally ended up in a hospital, versus I don't know that we've seen a study yet of being able to address the patient in a very initial acute phase of disease process and look at what that outcome shows versus more of a hospitalized patient outcome.
Exactly.
So
yeah.
My opinion on that is to be continued. I think if it's done safely and appropriately, that outcomes are good. I do have very big concerns about people sourcing this on their own from horse medication. Because I grew up as a farm girl, and horses take huge doses because they are huge beasts.
Right.
And a little is a lot.
Yeah. I really appreciated the education you provided on ivermectin, and just like echo the fact of that I've been sharing with people that they don't want to wait to take their COVID therapies until they're 2 or 3 days into something. It's like,
right.
They should have everything ready to go at home. So when the earliest symptoms, and then they start supporting their body, those initial moments are, I think, really important with these therapies. And I've seen them really help, like right at the beginning.
Yeah.
And
we can't discredit all of those patient cases of this happened, I did this, 24 hours later, my outcome was that.
Yeah.
We just don't have enough of those case ends of one to make that final call. And that's a really hard thing to study.
It really is. I mean, how do you gather people within the first 24 hours of a prodromal kind of symptomology? It's very difficult, but it's another tool, and I think there's a lot of them coming out, and we're just learning more and more about our immune system, if anything, about what needs to happen in those early phases. What immune cells do we need to support? When it's progressed, what do we need to do next? I think we've just learned so much. But
and we're going to continue to learn, because let's face it, there's going to be variant after variant, and they all are slightly different. And we've even seen that with some therapies, that early on drugs worked, better than others at certain early on variants, and then lost their mechanism as that virus mutated and changed. And that'll be something we forever chase, probably.
Yeah. Yes, I'd love to hear more about Kusslers and Clarks, and just kind of like how you like to interface with patients and doctors, and just kind of what you guys are up to these days. I mean, being from this area, you guys are like the main go-to. So I know of you well, but like just for some listeners to kind of learn about you, that'd be great to hear.
Oh, sure, of course. And I thank you for that. That really means a lot.
Yeah.
So I'm a compounding pharmacist, and I've had the privilege of doing compounding pharmacy, custom made medicine, functional medicine for over 20 years now. And I do own both compounding pharmacies. I own Kussler's compounding pharmacy in Snohomish, and it's licensed to serve Washington patients, and we ship all over the state of Washington and work with all sorts of doctors in the state. I also own Clark's compounding pharmacy. It's located in Bellevue, Washington, so a suburb of Seattle. And we are licensed in 9 states, and primarily so that we are able to expand our reach and help other like-minded doctors and patients in, some of the neighboring states, such as Oregon, Idaho, Arizona, Utah, Nevada. And I believe we're also licensed in New York, Minnesota, and Florida. think I got that list right on my brain. So what that means is if patients live in those states and if the naturopathic physicians are co-licensed in Washington, so say you're in Oregon ND, you would have to have Washington licensure also, and we can help those patients in Oregon as well. Other types of practitioners, PAs, ARNPs, MDs, do not have to have dual licensing. It's just a weird Washington thing. But what we are is we're a non-sterile compounding pharmacy, which means we don't do any injectables of any kind. That's not my passion. That's not what I am really wanting to do. And therefore, I stay in my lane of what I'm really good at and what we really are passionate about doing, which is helping patients with hormone replacement, with chronic disease, with really unique thyroid disorders or autoimmune conditions. We do a lot in the dermatology world also, which is kind of interesting and neat. And then with that, I do get the privilege, I get to teach and at a couple of universities local, UW, University of Washington, and Bastyr University. And I love doing things like this and interacting with doctors. And I love going into their offices and teaching them and helping them and doing big presentations nationally as well. So I get to wear a lot of hats.
Yeah.
But with that, it fuels my soul and makes me feel complete. So
that's great.
Yeah, and patients are welcome to call or reach out to our pharmacy anytime. We've been a lot more active since COVID. It's been on like Instagram and Facebook, and so we try to put out some really good, solid content on those platforms for patients. But they're also always welcome to reach out and talk with our pharmacists and doctors as well. We like to see ourselves as friendly pharmacists, so we're here to help be a part of that triad relationship of doctor, patient, and pharmacist, and keep patients safe with drug interactions and clinical questions and drug questions. So
wonderful. Well, I would love to finish up by just hearing, some parting words about like if there's someone out there that's been dealing with long COVID, say for 3 months or more, and kind of words of insight or inspiration or encouragement that you could provide would be really helpful.
Yeah, I'm happy to. So the first thing is if you've had COVID and you're not recovering like you think you should have from this virus, don't ignore it. I feel like the sooner that a patient gets on this pathway and starts taking care of the inflammation and these other conditions that maybe arise, the better the outcomes. I feel like the longer I see a patient sick, the harder it is to get them back to where they were. And so with that, what that means is, number one, reach out to your doctor that you already have a great relationship with and see where their knowledge base is and see if they're able to help you. If they're not able to provide much more to you, that's when you need to start reaching out and look for a different approach and look for some providers that have really spent some good time and education in being better, well-rounded in this area. And I know, Dr. Randy, you are very passionate about this, so I know you're a huge resource to our community on that. And then from there, you get to work with a team, and you have a team approach around you to help you navigate this, and that you're not alone. There are a lot of patients that feel just like that patient, and we are here to help.
Great. Yeah, I think that's wonderful. Yeah, I would agree that sometimes we have a tendency to explain away symptoms and things like that. And just, sort of think it's going to go away, or it's just something that's going to pass. But, if you keep saying that to yourself over and over, it's time to pay attention, and, reach out, that someone's not going to dismiss, what you're going through and take it seriously. People, like you said, it's establishing a team, but it's really great. And I just can't thank you enough. I think having you in the community gives us a lot of confidence to move forward into areas that we otherwise wouldn't. And you always put safety first. And I really, really respect that. You do your homework, you do your research, you don't roll something out until you've really kind of investigated and you get quality products and quality sources. So it's really gives us confidence.
Thank you so much. That means a lot.
Yeah, you're welcome. And thanks for being on with us. And I guess, catching up with you down the road would be great. I mean,
Yeah.
every couple of years, it seems like there's some more and more to talk about. So
It's wonderful. Yes. Keep in touch, and I know we'll do great things together.
thank you.
Take care.
Thanks for tuning in to this week's episode of Wild. If you liked the episode, please feel free to share it with your friends, neighbors, loved ones, anybody who you might think might be interested in this topic, and tune in for future episodes and also for our feature podcast guest. Have a good one.